I'd like to introduce Rahat Salamat. She is a pulmonologist and sleep specialist at the Valley Hospital. Okay, take it away. Thank you.
All right. Thank you, Kathy. Good evening, everyone. I am Dr. Salamat. I'm with Valley and doing pulmonary critical care and sleep medicine as mostly outpatient, and I do some in-house as well. I'm going to start with the topic for today, which is narcolepsy. Not many people are familiar with this probably diagnosis or disease, and as it is not very common disease among the other common diseases in sleep medicine, like sleep apnea. So I'm just going to go ahead and start. So narcolepsy is a disorder of mostly central origin, by which I mean it is originating in the brain, and it causes problems with sleep-wake mechanism. What happens is patients have problems with the sleep-wake control, and their sleep intrudes into their wakefulness, and when they're awake, the sleep intrudes, which obviously can cause a lot of problems for the patients. It is usually diagnosed by a tetrad of symptoms, which include daytime sleepiness, cataplexy, hallucinations, and sleep paralysis. Daytime sleepiness in narcoleptic patients is usually worse than what we normally see, and we objectively measure it by our Epworth Sleepiness Scale, which is a scale we use to question people about everyday activities and if they fall asleep during those activities. For example, talking to people, sitting watching TV or reading, or if they're not driving. Most of the patients with narcolepsy would have the score above 15. Most of the score is, the maximum on this score is 24, and it goes from 0, 1, 2, and 3, mild, moderate, or severe chances that they will fall asleep during these activities. Another important kind of diagnostic feature which brings it to attention is sleep attacks. People would fall asleep at times when they should not be doing daily normal activities, sometimes even talking to people. Sometimes it is an overwhelming impulse to fall asleep, and they can, even with driving, which can be very dangerous, they can fall asleep. Another thing which we look for is if their sleepiness improves with nap. Most of the patients would describe their nap being a power nap. They take 10-15 minutes of nap, and for the next 3-4 hours, they're fully alert and awake, and then they start falling asleep again. One diagnostic feature which is more specific for narcolepsy is cataplexy, because we can see sleepiness in lots of sleep disorders. Cataplexy is defined as usually an emotionally triggered, it's a muscle weakness, and it is emotionally triggered, usually with positive emotions like telling a joke or laughing or extremely happy. It can be triggered with negative emotions. It mostly involves your face, neck, and upper body part muscles. Most of the patients who come and are not diagnosed with sleepiness, or they have not had any symptoms of cataplexy, could develop it 3 to 5 years after their initial problems with daytime sleepiness. The lag time from the initial start of symptoms to the final diagnosis is usually 10 years, which is a long time because the symptoms are vague and mostly all the symptoms don't come together. Another symptom they feel is having hallucinations, mostly on falling asleep. Sometimes they can have them when they are waking up, but mostly most of them are visual, could be frightening, and they describe them sometimes as seeing images or seeing things, and they also realize that they are not, those things and images are not there. Unlike sometimes psychiatric symptoms when they do not have insight that those symptoms are hallucinations. Sleep paralysis, again, is very common in, especially in high school kids, and most of us have experienced it. It is not very specific to narcolepsy, but it adds to the tetrad of the diagnosis. People usually wake up, and for 1 to 2 minutes, they are unable to move. It can be very frightening. And it is present in 10 to 20, up to 25% cases in normal people. But mostly it would happen, people would say rarely. They could remember these episodes happening months or years ago. In narcolepsy, it is more frequent, could be seen every few weeks. So that points towards something which needs to be looked into. So narcolepsy's epidemiology-wise, there are, we look at it being a rare disease, but more recently, I think it is not so uncommon. It is not a very rare disease. The incidence has been described anywhere from 25 to 50 per 100,000 people. There are two types of narcolepsy. Type 1 is with cataplexy. Type 2 is without cataplexy. Like I said, it is more specific. Cataplexy symptom is more specific for narcolepsy. Other symptoms could be seen in other sleep disorders. For type 2, it's 20 to 34 per 100,000. Type 1 usually starts in early teens and early 20s, and it goes undiagnosed for a long period of time. Unfortunately, because since it starts in young age and is associated with other comorbidities or disorders, it's often missed. Like I mentioned before, lag time is up to 10 years. Going into the etiology, and I mentioned that it is a disorder of brain. There are neurons. There are sleep centers, there are awake centers, and there are certain neurons in what we call as a lateral hypothalamus. This is the lateral hypothalamus where it says in red orexin. What happens there is that these neurons secrete neuropeptide, which are called orexin A and orexin B. They're also called hypocretin because two different scientists discovered them. So one named them orexin, but later on they found out that hypocretin, same thing. These neurons secrete orexin. It goes and is to different parts of the brain, and it binds to these receptors, which are called OX1 or OX2 receptors. And these receptors in turn stimulate all these areas. These are the major stimulating areas which promote wakefulness. And the orexin has what we call as excitatory effects on it. It basically stimulates. And when these neurons are stimulated, they secrete further neuropeptides or neurohormones, neurotransmitters. Most important of them are histamine, dopamine, serotonin, norepinephrine. Most of us have heard about histamine. As we know, antihistamines, when we take, they make us sleepy. So histamine is a wake-promoting neurotransmitter. Serotonin, we have all heard of the Prozac group of medications. Those are serotonin reuptake inhibitors, so they kind of stimulate and promote wakefulness. Another function of orexin is that they stabilize our sleep and they stabilize our wakefulness. What I mean to say is that when you lose that control, it's kind of a switch on, switch off mechanism. When you lose that control, the sleep is intruded by wakefulness. So they have awakenings during the night and they have poor sleep at night, which causes daytime, which adds to the problem of daytime sleepiness, which is already there because the wakeful mechanism is not normal. They also prevent the sleep, especially the REM sleep. REM is a rapid eye movement, dream sleep, from coming into the daytime sleep. This is the most common thing that we see, and that these are all these things associated with hallucinations and the sleep paralysis. When we are dreaming, we do not move there is a disorder where people can lose that sort of a paralysis effect that we have during dreaming, so that we don't act out our dreams. That's why when you're awake, and patients with narcolepsy, when they get dream sleep, they suddenly lose tone in the muscles and they start dreaming and they have hallucinations. So the orexin and narcolepsy was discovered initially in dogs. They were found to have the same kind of receptor mutations that we found later on in humans. So narcolepsy could be because you lose the neurons, or you have problems with the receptors that orexin works on, or the level, the orexin is secreted, but the level is not high enough to stabilize the wakefulness and the sleep. So why do we lose these neurons? So there are hypotheses regarding what happens when people develop narcolepsy. There could be problems with loss of neurons. Most prevalent hypothesis is that there are some genetic factors, but alone genetic factors does not cause narcolepsy. They found these HLA-DQB1. These are haplotypes, human leukocyte antigen on white blood cells that we look at. 95% of the patients with narcolepsy would have this, but on the flip side, lots of normal people would have this, but they do not have narcolepsy. So this genetic, along with some environmental factor, triggers the loss of neurons, or triggers some abnormality in the receptors that even if the orexin is there, it is not functioning the way it's supposed to. One of the autoimmune hypotheses is that some viral, some bacterial, just like any other autoimmune diseases, you get a viral or a bacterial infection, and your body starts making antibodies to protect you against that infection, but unable to recognize and kind of cross reactivity with your own body's antibodies or the neurons, and it causes damage to those neurons or loss of those neurons. Interestingly, in 2009, H1N1 influenza, there was, after that epidemic, there was a surge of narcolepsy, especially in younger patients. And further investigations, they realized that the vaccine which was developed, which was called Pandemrix, which was only available in Europe, I don't think it was in USA, it was a different preparation. They started developing type 1 diabetes, and the theory was that there was a cross-reactivity of the protein, that ASO3, that specific vaccines cross-reacted, the antibodies cross-reacted with the neurons and the lateral hypothalamus and caused this narcolepsy surge after the epidemic. Secondary narcolepsy is another brain condition, or just like strokes or some inflammatory processes or some disorders can cause the direct damage to those brain cells, and that can cause, like tumors also, even the vascular malformations or strokes in that area can sometimes cause secondary narcolepsy, sometimes trauma also. Like I mentioned before, it is very difficult. It is not an easy diagnosis because we do not have anything 100% test which can diagnose yes and no for narcolepsy. We have to rule out other etiologies, other comorbidities with narcolepsy, other reasons for the patient could be sleepy. There are multiple other reasons patient could be sleepy, and that's mostly the presenting complaint. Sleep apnea, restless leg or periodic leg movements is a disorder where the dopamine deficiency in the brain causes patients to move their legs during the night, and it causes awakenings, and in turn causes poor sleep during the night and daytime sleepiness. Depression, anxiety, and psychiatric disorders can also cause daytime sleepiness. REM sleep behavior disorder, like I mentioned before, when we go into dream sleep, we do not act out our dreams, we are paralyzed, and there is a disorder where that mechanism because of neurodegenerative disorders is not there, and people start dreaming and they start doing whatever they are dreaming. If they're most of these dreams are kind of persecutory dreams. They're being chased. They are trying to save themselves as a family member, and they start acting out dreams and would wake up either falling or hitting their spouse or bed partner, and or hurting themselves. Sleepwalking is a disorder which can be confused and which can develop is coexistent with narcolepsy. It is again sleep-wake problem issues. Insomnia, fragmented sleep, like I mentioned, for multiple reasons, patients during the sleep, just like during awakening, they have REM, the sleep intrusion, same way they have awakening intrusion during their sleep. So they usually have fragmented sleep on. When they do not have a good night's sleep, they're sleepy, they're tired, and they can have difficulties with memory, focus, concentration, and are misdiagnosed with ADHD, especially if it is under teenagers and young adults. Obesity, because of decrease in orexin level, and also because the patients are so sleepy and tired that they're inactive and they have difficulty doing the activities, causes weight gain. High blood pressure also again is comorbidity. Obesity can also cause diabetes. High blood pressure, diabetes, obesity can cause increased risk of cardiovascular diseases. Most of these patients do struggle with cognitive problems and being disorganized, same symptoms kind of as ADHD. All these things are associated with narcolepsy and could cause sleepiness, tiredness, and needs to be ruled out. So the diagnostic evaluation of narcolepsy, how do we diagnose it? It starts with clinical evaluation. Most of the time presentation is sleepiness and tiredness and some vague symptoms that we have to ask specific questions, and in a way that patient is able to tell us their symptoms and dig more into it, so that we kind of, especially the cataplexy is very difficult to diagnose, and different patients have different experiences, and it's very hard, especially younger adults and teenagers, to actually clearly describe their symptoms. So some of the things that you can probe if they're sleepy most of the days, and by this minimum of 3 months sleepiness and tiredness, and then it doesn't go away and it keeps getting worse. If they are sleepy when they wake up after a good night's sleep, and if the naps are refreshing. The difference between other disorders and narcolepsy is that in narcolepsy type 1 especially, they describe them as power naps. They take 10, 20 minutes of nap and they feel fresh. Vivid dreams, and having the cataplexy, again, you have to dig out if they're having a muscle weakness when they are, telling a joke. But like I said, with negative emotions also it can be triggered. It's usually emotions trigger the cataplexy. And asking them about hallucinations, if they hear things or feel things or see things which are not there. And sleep paralysis mostly is usually on waking up. And the most important is that if you ask them if they have fallen on an occasion where they should not have really been falling asleep, or they did not intend to, or it was not even a boring situation where you would say, they would put them to sleep. So second step after the clinical evaluation and suspected narcolepsy is that we order sleep studies. Most of them would start with an in-lab sleep study, but if there is a suspicion for sleep apnea, diagnostic study, home sleep testing can be done. And if it is severe sleep apnea, it can be coexistent. And if you treat the sleep apnea, if it doesn't go away, then you need an in-lab sleep study, and followed by what we call as MSLT. Overnight sleep study would involve having the EEG, having extensive monitoring. Most patients would have difficulty falling asleep in the lab, but narcoleptic patients, they would fall asleep easily, but they have difficulty maintaining the sleep. So we do overnight sleep study, and then the next day, if we do not find any sleep disorder, any other sleep disorder, we keep them in the lab, and 1 or 2 hours after doing the in-lab sleep study, overnight study, we give them a chance. We do what we call as a nap study. It is called MSLT, multiple sleep latency test. What that involves is we give them a chance to stay awake, and we actually instruct them that they can try to stay awake and take 20-minute naps. Most of the patients, when they wake up early in the morning, they are not able to fall asleep. But narcolepsy patients, they would fall asleep. And second thing we look for is if they do fall asleep, do they start dreaming right away? And that's why we have the EEG. It can also tell us that they are dreaming or not. The dream sleep we see on the EEG, even though patient might or might not remember that they were dreaming. Most of these naps are 2 hours apart. What we're looking for is if they have 2 or more sleep onset, what we call as sleep onset REMs, that they fall asleep and they start dreaming. What else can give the MSLT or the sleep study which looks like narcolepsy? We need to rule out that the patient's depression, if they are depressed, it is under control. If they're sleep deprived, if they have not been sleeping, if they're chronic sleep deprived, as soon as we put them to sleep in the lab, they would fall asleep and also would start dreaming, which could be a false indication that they have narcolepsy. Also, people who have what we call as a night people, right? They call themselves out. They stay up until 2 or 3 in the morning, and when we put them in the sleep lab, that's their peak time to dream, and that's their peak time to go into deep sleep. The deep and the dream sleeps come in cycles, 20 to 30-minute cycles, and when we are trying to do the naps, that's their peak time to dream, and it can give us a false positive MSLT test. So that needs to be kept looked at. Their sleep schedule is very important. Some medications causing the sleepiness, some medications when they're taken off, like especially the antidepressants. Antidepressants suppress your REM sleep or dream sleep, and when they're taken off, people can start dreaming, and it could give false positive test. So most of the time when we do this test, we ask patients to be off of any medications for at least 2 or 3 weeks. Sleep apnea, if it is there and it is untreated, can also give the positive MSLT. So these are all the disorders which needs to be ruled out. The lab test, unfortunately, there is no commonly done diagnostic test which can give us for sure that this is narcolepsy, especially in type 2, which is more difficult to diagnose. Type 1, it could be easy. The orexin level can be done in CSF. CSF is cerebrospinal fluid. It can be invasive. What we have to do is we have to do lumbar puncture. You have to put in a needle after numbing up the lower back, just like sometimes we give anesthesia. We take the fluid out and send it. The only available centers is you have to send it to Mayo Clinic, or there was in California. The one in the California is not there anymore. It is very logistically difficult to do the test, and it's very rare that patients would agree to having something like this done. Also, it's logistically very difficult. In research centers, yes, it's possible. Again, the HLA testing is not done routinely. Like I mentioned, that most of the 90% of the 99% of the positive individuals do not have narcolepsy. So it does not add really much doing it, because 40%, 12 to 40% are positive and they do not have narcolepsy. So what do we do? It's a diagnostic criteria which is set by American Academy of Sleep Medicine, says that for diagnosis of type 1, we have to have A and B criteria, which means that for at least 3 months, criteria A is they have to be sleepy for at least 3 months, and then any one of these or both these criteria. One is cataplexy, and a positive MSLT, or if you're able to check the CSF hypocretin, that level is less than 110. So that's why you don't have to have both criteria. Cataplexy with MSLT positive could be enough to diagnose type 1. For type 2, I'm sorry, this is I think a typo. It was a type 2 narcolepsy diagnosis. It's more difficult, like I said, to diagnose, and you need more data, more criteria. You have 5 criteria. Again, that they should be sleepy for 3 months. The mean sleep latency time should be less than 8 minutes. And they do not have cataplexy. That's why it's called type 2 narcolepsy. And either your CSF hypocretin level could not be measured, or when it is measured, it is more than 110. And you have ruled out all the other causes of sleepiness and tiredness, and those MSLT findings could only be related to narcolepsy. The other issue we come across is the MSLT is not like a 100% diagnostic test. Especially in type 2, there are limitations, there is poor reproducibility, and it can be positive in another disorder which is called idiopathic hypersomnia, which again is a disorder which is a central sleepiness disorder, but we do not know exactly the diagnosis. They do not fall into the narcolepsy, and when we cannot explain, unfortunately, we do not have enough information on this disorder we just classify them as idiopathic, meaning we do not know the cause. And if patients are presenting, again, going back to the clinical, if they're having REM sleep dysfunction, like cataplexy, or they're having sleep paralysis, they're having hypnagogic hallucinations, it goes more with narcolepsy type 2 rather than idiopathic hypersomnia. Clinically, also, the narcolepsy patients feel better with the naps. Idiopathic hypersomnia patients, they take long naps, 2-3 hours naps, and they still feel tired. Narcoleptic patients, on the other hand, they would feel fresh after the naps. Clinically, that might help with diagnosis. So coming down to treatment. Treatment of narcolepsy, there are non-pharmacological therapies which are most important. We need to rule out, like I mentioned before, all these other comorbid conditions. We need to treat them. Naps, especially for kids and especially for teenagers, if possible, or at work, we do prescribe sometimes actually for kids. You can write a prescription for the school that they should have time for a 20-minute nap, by which you can cut down the amount of stimulants that they're using, because sometimes even the very strong stimulants might not work for them, or especially daytime, they need to be functioning, they need to be fully alert during the school and at work time. So they can take a nap, a quick 20-minute nap, that helps, or they might have to take another stimulant. Sleep hygiene, and I'm going to, in my next slide, go a little bit more in detail in the sleep hygiene, is very important. And avoid sleep deprivation. They should get at least, their quality of sleep is not great, they should get at least 7 hours of sleep. Certain medications like hypnotics or pain medications or benzodiazepine, anxiety medications, alcohol, they can worsen the sleepiness, and if possible should be avoided in narcolepsy. Insomnia causing medications like caffeine or theophylline, they already have a poor nighttime sleep, so avoid anything which would cause insomnia. Prazosin is a different group of medication, which is an alpha-1 agonist. It can worsen cataplexy, so it should be avoided. Psychosocial support, again, is very important, especially in kids, teenagers. It is very difficult, and also at workplace, it is very difficult for people how they are perceived. Some people, I'll tell you, I had a patient. She had cataplexy and narcolepsy since she was a teenager in high school. She almost dropped out of high school because everybody kept calling her that she's lazy, she's sleeping. The teachers were not aware that she's sleeping in the class, she's not able to turn in the homework, she's not able to perform, and she was always labeled as being lazy. people perceive it that they're not motivated, they're not organized, so they can have problems at work and at school. So support groups and recognizing and educating people is important, especially in school and in teenagers. In high school, they need to be a little bit, they need a support so that they can be functional and during the daytime. Health maintenance, like I mentioned, these patients have comorbidities, they have anxiety, they have high blood pressure, obesity, diabetes. All these needs to be taken care of by primary care physician and appropriately treated, keeping in mind avoiding the medications which could worsen their symptoms. So a little bit more about sleep hygiene, which is very important, and especially for the kids and teenagers. It is hard to maintain them on a routine and allowing them to get at least 7-8 hours of sleep, having a regular bedtime, wake-up time, not to take too long naps, because more than 1 hour nap could put them into deep sleep and what we call as a sleep inertia. Then it's very hard to wake them up. Also, it disrupts their nighttime sleep. Avoiding any stimulants like caffeine, nicotine, doing heavy exercise within 2 hours of bedtime, and eating close to bedtime. All these things should be avoided as they disrupt your nighttime sleep. Having a sleep environment which is quiet, which is dark, and avoiding, especially this day and age, we have all these electronics. They also are causing problems with their sleep onset and sleep maintenance. It disrupts your sleep by suppressing your body's melatonin, which is secreted at night, to help you fall asleep and maintain sleep. Especially teenagers, when they're using all these electronics close to bedtime, not only does it stimulate their brain, but it also suppresses their melatonin, and their nighttime sleep is already worse. It makes it worse for them. Okay, so treatment-wise, again, I'm bringing this thing up again. Unfortunately, we cannot do anything if the neurons are destroyed or the level of orexin which is secreted. What we do is we work on the medications, and all the medications that we have, they work further down, which means orexin was supposed to stimulate these neurons to secrete the norepinephrine, serotonin, dopamine, histamine. These are all awake neuropeptides. What we have, the medications, we cannot fix this, but what we do is most of the medications that we use are stimulants and increase the levels of these hormones, either by decreasing their uptake or what we call as a metabolism, so that they dissipate, or by increasing their levels so that they're slowly metabolized or not metabolized. So there are different medications which would help with daytime sleepiness and different medications which would help with cataplexy. So most common first line being used is modafinil. So it was a big success because the only medications that we had initially were the amphetamines. And obviously there is an addiction potential. These are side effects. They cause hypertension, they have addiction, and they cause tolerance. So there was a lot of problem with those kind of medications. The newer medication which came out after the amphetamines was modafinil and R-modafinil. R is a same medication, just a longer half-life. The modafinil has short half-life. Exact mechanism is not known, but it is now a first line of therapy, and we use it increases the dopaminergic basically signals, and it blocks the dopamine reuptake. Like I mentioned before, so this is the all these hormones, these are going to be increased. So it increases the dopamine levels. And the newer medication which came out, which is called solriamfetol, is again, it's a progress. These two medications, solriamfetol and pitolisant, these are recently approved over the last 1 year. It's actually a good addition to narrow list of medications that we had to try for narcolepsy, especially, which would not have the addiction potential. These are, again, the dopamine and norepinephrine reuptake inhibitors, so increase the levels. H3, pitolisant, is an agonist. So what they came up with most of the time was, it is going to enhance the level of histamine and again improve the daytime sleepiness. So by increasing the levels of dopamine, norepinephrine, and histamine, which are all these, I showed you, histamine, dopamine, norepinephrine, they are going to increase your level of alertness. Methylphenidates and amphetamines that we used to use in the past, we're still using them for kind of breakthrough and for severe symptoms, norepi and dopamine neurotransmitters. So second treatment is for cataplexy. Cataplexy can be very debilitating for some patients. The example I gave you for that girl that I have, she was at a grocery store and she saw something funny, and the next thing she knows, she's dropped on the floor, and then she hit herself. They never lose consciousness, so she hit herself, and she had injury, and so it can be. And if you have frequent cataplectic episodes, it can be very debilitating for the patients, and especially the teenagers, they start avoiding any circumstances which would bring on the cataplexy. So what we had been using in the past was REM suppressing. These are the oldest medications that we use. These are basically all these SSRI inhibitors, REM sleep inhibitors, through a different mechanism and pathway, and the tricyclic antidepressants and the SSNRIs, fluoxetine, the Prozac group of medications, and the venlafaxine effects. They suppress their REM, and when you have suppression of REM, it reduces the episodes of cataplexy. Another very effective medication was gamma hydroxybutyrate. It is a GABA metabolite. The exact mechanism, again, is not known, but it works on what we call as gamma amino butyric acid beta receptors in the brain, and it is unique in a way, and it was the only medication at some point which was effective for cataplexy. It improves their nighttime sleep, and it improves their daytime sleepiness. It gives them into deep sleep. The downside of this medication is that it is very expensive, and I think it got a bad name years ago. It was used as a kind of a street drug, date rape drugs, and people were scared. It's very expensive. Now it is with specialized pharmacies. Most of these medications are controlled substances. And it has a lot of sodium, very high content of sodium, the way it's mixed. And so people who have high blood pressure can be a problem, or heart disease. Second problem with the dosing is that you have to take it when you go to bed, and then you have to set up an alarm and wake up and do a second dose. They're working on a long-acting one, which is probably be available by next year, so that you don't have to wake up in the middle of the night to take the second dose. Pitolisant, relatively new, very promising. It has, again, H3 receptor. It not only reduces sleepiness, but it also increases, it helps with cataplexy. And it is once a day dosing, and it is not controlled, which is a big thing. But this is one of the medication which is not controlled. All the other medications are controlled substances. So kind of what other things we need to consider around narcolepsy driving safety. Narcoleptic patients are at risk of 3 to 5 times for a car crash. 1/3 already have had an accident by the time they're diagnosed. Long highways, long drives are especially difficult. Despite taking modafinil, which does improve driving performance, they can still have problems driving. Having a family or caregiver making the patient aware of the sleepiness, because sometimes patients are not able to recognize, and especially when they're having the sleep attacks or the sleepiness, that can be helpful. Sometimes we are able to do the wakefulness test, and we, just like we have MSLT, we put them and give them nap studies and ask them to stay awake and see if they can. So it's called a maintenance of wakefulness test. It is discouraged for narcoleptic patients to work as commercial drivers. as much as we would like to bring them back to their baseline functioning, unfortunately, it's not possible. There is some vague daytime sleepiness despite all these medications, frequent medications that these patients have, and they are at high risk of car accidents. So the safe driving around time for 30 minutes, they might not have any issues, but once you push them to long, monotonous highway drives, it is difficult for them. Towards the end, I just want to say, since it is a disease mostly in younger patients, they need a lot of support. This is a very good narcolepsy network support group, and it's an organization. It's been working since 1986. You can go on their website, and they have all kinds of work that they're doing. And they're actually having all these young people come out and educate, even in high schools, even in community centers, patients who have narcolepsy, to tell about their personal experiences, and so that they can have a conducive environment in high schools and help, especially the younger kids and the adults, to help them in the school. So it's a good organization. So I think that's it, and I can take any questions.
Okay, if anybody has any questions, please type them into the chat or into the Q&A. Okay. Doesn't look like anybody has any questions, Doctor. Okay, so just a reminder to take a few minutes to fill out the survey using the Survey Monkey link that could be found on the bottom of the email you received. If you're interested in future Valley Live events, please visit us at valleyhealth.com/events. Thank you, Dr. Salamat, and everyone have a good evening.
Have a good evening. Thank you.
Dr. Salamat?
Yes.
Oh, someone is thanking you very much for all you've done for her.
Oh, okay.
All right. I can't say her name because of HIPAA, but yeah.
Sure.
All right.
Good to know.
Oh, wait, I do have a question. Someone is asking, what if a person's sleeping difficulties and cannot fall asleep at all?
So that's more insomnia, and it needs to be evaluated. The reason why they cannot fall asleep or stay asleep. Obviously, if they have difficulty falling asleep, staying asleep, they do not get enough sleep during the night, they are going to have problems with the daytime sleepiness during the day. So we try to treat the cause and not the symptom. So if they're feeling sleepy during the daytime and their problems are due with the nighttime sleep, so we fix the problem and then see how it improves their daytime sleepiness.
Okay, I believe that's it. Okay, thank you again, everybody. Thank you, Doctor.
All right, thank you, Kathy. Thank you. Have a good evening, everyone.
Good evening.
Bye-bye.